This video is intended for medical professional education and is aimed primarily at anaesthetists. It does not contain any identifiable patient information, individual case discussions, or hospital-specific audit data. The views expressed in this video are those of the individuals, and no specific drug or technique discussed should be adopted for any given patient without a full assessment by a qualified anaesthetist and the treating team.
Good evening, everyone, and a very warm welcome to our advanced session on methadone. First and foremost, I'd like to thank the ASA for generously hosting tonight's session. A special thank you to Dr. Vida Vilunas, ASA President, for her encouragement and ongoing support, and to Dr. Susie Nu, who has been a tireless supporter of Advanced since its very inception. We are also gratefully acknowledging ANSCA, who have supported Advance from the outset. A massive thank you to the ASA events team, Rianne, Penny, and Rachel, who have worked tirelessly behind the scenes, managing more than 900 registrations. Advance has grown enormously over the past few years, but our mission remains the same: to share evidence-based, thought-provoking discussions that are relevant to our everyday clinical practice. For those joining us for the first time, a huge welcome. We're thrilled to have you, and we hope to see you at our future sessions. My name is Sarah Lee. I'm a staff anaesthetist at Eastern Health, and I founded Advance back in 2022. What began as a small teaching session at Box Hill has now expanded across Australia. I'd like to thank my directors, Dr. Clive Ruckbook and Dr. Tim McIver, for their encouragement, and our entire Eastern Health Anaesthesia department for continuing to show up and support the team. Now, tonight, we're very privileged to have an exceptional panel. Professor David Scott, our past ANSCA president and former chair of the VPCC, Dr. Noam Winter, who's the head of pain at the Alfred Hospital. Also joining us heroically, given the time difference, are Professors James Ye, Stephanie Pan, and Thomas Anderson from Stanford University, authors of the comprehensive update on intraoperative methadone use published in Anesthesiology this September. It's also a very special privilege for me to have Dr. Jeffrey Gourlay with us. For many of you who may not know, he's the original pioneer whose groundbreaking work on pain and methadone shaped decades of research. His studies have inspired many, including Professor Evan Koresh, who often refers to Jeff as the spark behind his own landmark work. Jeff, it's an honor to have you here. Thank you for joining us. Now, many people have asked how we managed to gather such an incredible group of experts tonight. It's simply a reflection of how genuinely passionate these leaders are about the topic that we are sharing tonight, and we are humbled that they've chosen to share their time and wisdom with all of us. I'd like to also thank Dr. Yasmin Endlich, Chair of WebES, and her team for sharing methadone-related data with us. And of course, Dr. Jane Anderson and Miss Caroline McLaughlin from Epworth for coordinating the practitioner survey, which we'll be sharing the results shortly. We're also deeply grateful to Professor Evan Koresh from Duke University for recording a special pre-meeting interview with us. As one of the world's leading researchers on methadone and former editor-in-chief of Anesthesiology, his insights have been very valuable. Now, co-chairing tonight's session with me are Dr. Harsh Dubey, one of our VMO anaesthetists at Eastern Health, who's been with Advance since the very first session and has co-chaired the last few meetings with myself. Dr. Stuart Watson, another wonderful colleague at Eastern Health, whose thoughtful inputs has helped us stitch together this session today. And of course, our literature review will be shared by Dr. John Webster, one of our senior trainees, who's soon to begin a fellowship at the Alfred and Monash Health next year. I have to say it was hard to keep up with Stuart and John. Being both Renton Prize winners, they managed to take the pharmacokinetics of methadone to a whole new level. So today's advanced session is an evidence-based discussion on peri-op methadone use. It's a chance for us to share ideas and appreciate the diversity in our anesthetic practice. We'll explore methadone's unique pharmacology, its potential for good and great analgesia, and of course, the risk when it's misused. This isn't a debate about sustained release opioids or a forum for criticism, and it's certainly not a guideline, but an opportunity for us to reflect, discuss, and learn from one another. And now I'll hand over the mic to Harsh.
Tonight's discussion will cover several key areas. We'll begin with an overview of methadone's pharmacology and its clinical applications. We'll then move on to dosing strategies and specifics around patient selection, exploring how and when methadone may be used appropriately and safely in the perioperative setting. We'll examine its potential benefits, its safety profile, and we'll also be including some practical considerations towards the end of the talk, which can increase and optimize the safety profile when it is used. And we'll also be conducting interactive polls, all the while sharing survey results and prompting discussion. We have an exceptional expert panel here today, so we'll be making full use of their expertise. But I would like to just emphasize that we are by no means experts in this area. Our role as panelists tonight is simply to share the evidence and to open up conversation. For those who may not have had a chance to read this clinical update, it was published in Anaesthesiology in September this year and has incorporated data generated between 2019 and 2025. You can see just in the bottom right-hand corner, there's a QR code superimposed on a coffee mug. You can access the full article across this presentation whenever that QR code is present. Just scan it and it'll take you straight there. We will, of course, be going over dosing today, some safety benefits and drawbacks in significant detail, but it would be great to briefly invite the first author of this paper, Professor James Siet, to give us some introductory insights. Professor Siet, can we start with what you found particularly interesting as you wrote this paper?
Thank you so much for the invitation to be here, and it's an honor to speak with the gathered attendees. So I have to credit my colleagues, Dr. Pan and Dr. Anderson, for working with me on this work. But where we started with this article was to pick up from where the previous clinical focus review, where Dr. Murphy and Dr. Sokol had reviewed studies from 1982 to 2019. And in the span from 2019 to 2024, there are actually more studies on methadone than they actually cited previously. So the incredible growth and interest in using intraoperative methadone, in other words, so specifically, apart from the use of oral methadone in chronic pain, intravenous methadone for intraoperative use is a kind of narrow subset of how methadone could be used, specifically in opioid naive patients, that is different than many practitioners are used to using in the setting of either chronic pain or in the setting of medically assisted treatment for patients with opioid use disorder. So that's kind of the big highlight, is that in the last 5 years, a lot more people are speaking about how are we using this, in what settings can we use it, and when is it safe and potentially actually more effective to do so. And I think what we conclude is that as there are more studies coming out, both of the retrospective nature, but also the well-designed prospective studies, I think there's mounting evidence that intraoperative, intravenous methadone use is a compelling modality to help us address analgesia in the perioperative setting.
Thanks, James. Methadone's use is obviously expanding quite significantly, especially in Australia, and we'll see that over the course of this presentation as we go through the poll results. As an author of this article and as someone who's very well versed in the literature, did you find any significant evidence-based reasons or drawbacks against the use of methadone?
Surprisingly, no. So we titled our article A Comprehensive Update on the Use of Intraoperative Methadone because we followed, although we didn't call it exactly a systematic review, we essentially used the rigorous methodology of one and conducted a very extensive literature search. So that's why, again, I mentioned the monumental work that Dr. Pan, Dr. Anderson, and I conducted, because we scoured the breadth of the literature to see, well, what were the findings, either positive or negative. And the majority of studies were either neutral or positive, in the sense that methadone had either greater efficacy or minimal negative safety profile, in the sense that compared to traditional opioid analgesic strategies, there weren't significant drawbacks that traditionally many practitioners have held kind of reservations, and appropriately so. But there is now mounting evidence that we can say for these specific types of operations, And in these specific settings, there may be a compelling argument to use methadone.
Thank you so much.
Taking a look now at the survey responses for Advance, we actually had more than 700 submissions, which is quite a large number considering where Advance started from a short time ago. So hats off to Sarah for organising something at this scale. Most of the people who responded were consultants. About 2/3 of them were doing a mixture of public and private practice, with the remainder doing majority private practice. We also were keen to see the age split of level of experience of the people responding. It looked like most of the people were fairly experienced as far as the respondents went. The reason we asked this question was to figure out whether there was any relationship between years of experience and propensity to use methadone. About half of the respondents didn't use methadone at all, and of those, the other half were kind of evenly split. So 12% using it on a regular basis, 20% using occasionally, and 17% using rarely. Splitting the data another way, it looked like the people who used methadone the most were more likely to be experienced anaesthetists, and that was also the case with people who'd never used or didn't use it at all. And for those using methadone just occasionally or moderately, that was kind of evenly split across these cohorts.
So this was a survey that Jane sent out. Thank you all for completing the data. There were a total of 85 respondents. And of course, the greatest reported barriers to methadone use were concerns around respiratory depression and the absence of institutional policies or support for its use. Now, some respondents also raised issues related to cardiac safety and the drug's prolonged duration of action. I'd be interested to hear from James, Stephanie, or Tony whether there are similar concerns within your institutions or in the States.
There are certainly similar concerns. I would say the concerns that you've shared and the panel has shared about methadone use in patients there, very similar to concerns here. However, as James pointed out, we have not found anything in the literature to suggest or minimal suggestion that these are concerns that are greater than those that occur with other longer acting opioids. The QTC prolongation, there's a great small and retrospective PICU study which shows, as was previously suggested, that it takes a very large dose of methadone and a prolonged use of methadone to prolong QTC.
Thanks so much, Tony. And for the next question that was asked, what are the main reasons for choosing methadone over other opioids? And of course, most reported choosing it because of its longer duration of action, its opioid-sparing effects, and its perceived benefits in patients who have opioid tolerance or have chronic pain. Others included the possibility of reduction in post-op nausea, vomiting, and there was a mention of a smoother wake-up in ICU specifically for cardiac surgery, as there might be some perceived blunting of inflammatory response to the cardiopulmonary bypass. Other interesting points that were made included mood elevation and a potential reduction in chronic post-surgical pain.
So looking at our advanced data, we found a similar spread in the highest prevalence of methadone use being for patients with chronic pain. We can see that there's a significant overlap there with chronic pain and spine surgery, which was also up there. Major abdominal surgery, orthopedic surgery also were quite well represented. In particular areas where intrathecal morphine use has been declining, like within ERAS protocols, for example, within orthopedic surgery, methadone was found to be particularly popular, given that it doesn't typically come with the side effect profile of pruritus and urinary retention. All right, John, now over to you for a pharmacology review.
So I'm John Webster. It's easy for me to get lost in the weeds of pharmacology, so sorry about that. Methadone was first synthesized in Germany in 1937, and as we all remember from the primary, it's racemic, which is great. So it's got a levo and a dextro enantiomer. And the relevance of that is that they actually have different actions. So the levo enantiomer has 10 times the potency of the mu-opioid receptor and is responsible for most of the opioid analgesia, whilst the dextro one has the majority of the NMDA antagonism effects and the serotonin and noradrenergic effects. So we do have a little quiz here that should pop up as a poll. So there's two questions. When is the peak onset of analgesia following IV methadone administration? And when is the peak respiratory depression following IV methadone administration? We might throw to some of our panelists here to give some suggestions to the answer. David Scott, if you would like to comment on what you think the answers to this might be for us.
Thanks very much, and thanks for inviting me and the others to this fantastic presentation and discussion. Methadone is highly lipophilic. It behaves intravenously acutely a lot like fentanyl, and that its peak effect will be around about 5 to 10 minutes. So I think in terms of immediate analgesia, that's a desirable characteristic. It's a little slower than oxycodone and quite a bit slower, obviously, than intravenous morphine. In terms of peak respiratory depression time, it's said to be around about 30 to 45 minutes. It could be B or C, but probably 45 minutes afterwards. I would suggest that to be conservative, you would be looking at least an hour, if not 1 to 2 hours. But then from then on, we're dealing with the differences of methadone in terms of the way it has redistributed, how it's released from tissues, and how it's metabolized in a very variable way. So the tail end of this story is quite different to the start of this story.
So we'll launch the second poll now, and
we might get
someone else to give their opinion as well. Stephanie, Pan, from your comprehensive update, what were your findings in terms of the peak respiratory and analgesic effects?
Actually, in our clinical focus review, we represented this data. Actually, it's from Stemlin's publication. And they literally quote that after a single bolus that the peak respiratory depression occurs within 30 to 45 minutes, which is fairly interesting, especially given the long analgesic effects of methadone that we usually associate with methadone. And then also very surprising within the clinical focus review that we did was another study by Carle, which actually focused on both intravenous methadone use in cardiac and spine surgeries. And when they looked at time from extubation to even need of naloxone, comparing methadone and other opioids, specifically morphine, they found that the interval for methadone was actually much shorter, within 98 minutes, as opposed to with morphine, which is about 247 minutes. So if anything, if you're going to see some respiratory depression that you should be treating, methadone actually offers you a smaller time interval in which to capture that. And one could argue it might be a little bit safer in that regard. So B would be the answer.
Yeah. Thank you, Stephanie. So in terms of the pharmacokinetics, good oral bioavailability, not really relevant for us in the context that we're using it. Those are its features there. Of note, it does cross the placenta and it does enter the breast milk, but not in clinically significant concentrations for standard perioperative IV dosing. And as David said, it's similar to fentanyl in its T-half KO and time to peak analgesic effect. So most sources suggest 6 to 8 minutes is the time to peak analgesic effect. And as we kind of discussed, the initial offset is via redistribution as opposed to elimination. So that table there just shows the different T-half KOs. And as you can see there, morphine is actually a few hours. So morphine takes a very long time to peak because of its hydrophilic nature. Metabolism is interesting for methadone. A lot of people have some concerns with it due to the pharmacogenetic variation regarding its clearance. But as we briefly mentioned, so the T-half alpha, which is the distribution half-life, is actually only 6 minutes. So that's probably why clinically we see a respiratory depressant peak period, at least, to be at a maximum of 30 minutes, which is 5 half-lives of that distribution half-life. So your plasma level and your central compartment will rapidly fall over that first 30 minutes. Obviously, the T-half beta is very long, a mean of 26 hours, and that's one of the things that gives methadone its unique properties. There's a small amount of renal excretion, which does have some considerations to give in the patients with renal impairment. But I think, as we kind of alluded to here, the peak effect is very early. And given the concerns around pharmacogenetic variation, I would just like to draw the comparison to other drugs that we use very readily that have active metabolites and therefore much more unpredictable peak effects and time to peak effects. So oxycodone is metabolized to oxymorphone, which is actually 14 times more potent, and it's subjected to the 2D6 pathway, which also carries a lot of pharmacogenetic variation. Similarly, tramadol is metabolized to M1 tramadol, which is 4 to 6 times more potent at the mu receptor, and therefore are subject to pretty significant changes in individual variability, but there doesn't seem to be much hesitance in using these for that reason. So it's interesting that the concern lies with methadone, but not with other agents that share similar issues. In terms of the duration of action, so there's a lot of discussion around the duration being dependent on the dose given. And that's true to a certain extent, but it's also true to a certain extent with any lipid-soluble drug. Typically, doses more than 20 milligrams in a 70-kilo adult will achieve a plasma concentration greater than 30 nanograms per mil and tissue levels that mimic that. And therefore, the elimination is by the T-half beta of 26 hours as the mean time. And so they have a prolonged analgesic period. Similarly, the duration of respiratory depression will mimic that if you give a dose that is big enough to cause their tissue levels to exceed the requirement for respiratory depression, which typically for methadone in isolation is greater than 100 nanograms per mil, which means that typically for a 70-kilo adult, you'd probably have to give 70 milligrams of IV methadone in order to cause prolonged T-half beta kinetics for respiratory depression. Obviously, this is methadone in isolation to cause that respiratory threshold, and so consideration does need to be given in terms of synergistic drugs such as benzos and gabapentinoids. The clinical effects of methadone, which is why we're using it, so it's essentially a multimodal analgesic as a single agent. It can be used to decrease opioid-induced hyperalgesia and chronic pain and transitions to acute, subacute, and potentially chronic opioid tolerance. It has serotonergic effects, which increase descending inhibition and have anti-nociception effects through decreasing wide dynamic range interneuron activation, as well as being a potent analgesic. This graph here is essentially what we're talking about with the difference between the T-half alpha and T-half beta pharmacokinetics. The main graph is for 5, 10, 20, and 30 milligrams when they're given, and the prolonged elimination half-life of that. The inset in the top right is a shortened time interval that shows the T-half alpha kinetics. And you can see from that that even if you give 30 milligrams of methadone, which is the top line, initially it will exceed the level for respiratory depression. However, within 30 minutes, due to that redistribution, it's actually fallen below the level required to cause respiratory depression and will just give prolonged analgesia. And just to kind of draw a little bit of comfort for people, that, as David Scott mentioned, is very similar to the pharmacokinetics of fentanyl. So if you give a big dose of fentanyl, there is an initial rapid redistribution and offset, but then there is a prolonged elimination phase with, if you give a big dose of fentanyl, up to 10 hours, there's still a noticeable plasma level of fentanyl. I think the point to make here as well is if you're using something like fentanyl to blunt your laryngoscopy and then giving methadone, you need to give consideration to the lingering fentanyl effects and pairing that with your methadone and the risk of the additive opioid effects many hours from now, and that using an ultra short acting opioid might be better for laryngoscopy. We now have a video from Professor Karash over in the US.
One of the questions that I think a lot of our audience would like to ask, potentially because of their concerns about the side effects of methadone, is what do you think is the peak time to respiratory depressant effect of methadone? When would you see a person being so-called the most sedated after a dose of methadone? And I know that this depends on the actual dose, but if, let's say, we do give a bolus of about 5 milligrams pre-induction, when would we expect the person to actually have the peak respiratory depressant effect?
The onset time of methadone is very rapid. As you mentioned, it approximates that of fentanyl. And so we look and have measured onset time. We tend to do it by measuring pupil diameter because it's the most sensitive measure we have of opioid effect. And the onset of intravenous methadone is within minutes, and the peak effect occurs within approximately 10 to 15 minutes. So it's very rapid. If, for example, we're giving it an induction, peak effects are while the patient is anesthetized.
There is a very beautiful graph that is in one of the clinical reviews that I believe is from you. It's a graph that shows that within 45 minutes, despite the actual dose of methadone, whether it's a 10 milligrams, 20 or 30 milligrams, 0.3 milligrams per kilogram bolus, that after 45 minutes, the redistribution probably will impact the respiratory depressant effect in that someone should, if by 45 minutes you do not see a respiratory depressant effect that's significant, they probably will be okay. Have I interpreted that graph correctly?
Yes, you have. Now, that's a little bit of an idealized graph, and it's based on pharmacokinetic calculations. But I can certainly tell you from experience that I do not see significant respiratory depression. And we just have We've done several clinical studies where we have looked at that. We do not see any significant respiratory depression. I will tell you that I'm in the process of completing a very large meta-analysis, and that the results of that show that the postoperative incidence of postoperative respiratory depression, regardless of how you measure it or define it, doesn't differ between methadone and other perioperative opioids. Now, it is true that all opioids will depress respiration. If we look at patients in the recovery room who've gotten some opioid in the recovery room, we see that they have some elevated end-tidal carbon dioxide concentrations. So it's very typical that after the clinical doses that we use in the operating room, patients will typically, once we get them breathing spontaneously, will typically have an end-tidal CO2 in the high 40s or maybe low 50s. They'll be breathing about 10 to 12 times a minute, and they wake up completely comfortably. Every once in a while, they may be breathing a little bit faster, and they might wake up a little uncomfortable. So what we do is we titrate a little bit more methadone before they wake up to make sure that they do wake up comfortably.
The next lot of survey data explored the dosing that was typically employed by anaesthetists that responded to the survey. So we can see a degree of heterogeneity here. The largest single group tends to use a single dose of 10 milligrams, perhaps as a reflection of their particular subspecialty work, not requiring much more than that. The second largest group rather uses a dose based upon whether the patient's undergoing a day operation, an overnight stay, and potentially considering a higher dose of 20 milligrams or so for other operations that are a little bit larger. The most popular body weight-based dosing strategy appeared to be based on ideal body weight with adjusted lean and total following. A much smaller group. Perhaps at this point, we can call on a local expert, perhaps Dr. Noam Winter from the Alfred. Can you talk us through a potential dosing strategy using methadone for a opioid-naive patient in their mid-50s having a large spinal operation?
Yeah, thank you. Yeah, so I tend to advise the 0.2 milligrams per kilo of, I guess, ideal body weight or lean body weight as a general rule. And in general, how that tends to be is it tends to work out at about 15 milligrams for most people. I always tell people if you're going to use methadone, you want the surgery to be greater than sort of 2 hours in duration, and it's generally a 2 ampule case. So obviously it comes in 10 milligram ampules, and you're generally using sort of the 15 to 20 milligram range.
And perhaps going a little more internationally, Dr. Stephanie Pan, would you agree with that sort of a dosing strategy, or would you do something different?
Yeah, there are definitely different dosing strategies, both for pediatrics and even for adults. But I would say at least dose it to at least 0.15 milligrams per kilo, usually adjusted body weight or ideal body weight, so that you at least get some minimum analgesic effect. And so that's what I would typically use, especially for any type of like same day or ambulatory surgery. And even one of these really kind of surprising studies from Lisa Einhorn, she studied methadone in pediatric total tonsillectomies. And so those are very short procedures, and they were able to go up to about 0.15 milligrams per kilo, saying that they were still giving additional opioids on top of that, even post-op. If this were a kind of overnight stay or someone who had chronic pain, definitely at least like 0.2 milligrams per kilo. And I would even, if it's a long surgery, I would even think about redosing it at the end based off of either pain scores by the patient or even respiratory rate, in which case that supplemental bolus could be anywhere between 0.03 to 0.05 milligrams per kilo.
So for a two-level anterior and posterior spinal fusion operation done in someone in their mid-50s who's opioid naive, would I be right to assume that you'd be considering a dose around sort of 0.3 per kilo with supplemental dosing available post-op?
I would probably start out with 0.2 milligrams per kilo and then see how they do towards the end. And you could probably work your way up to that 0.3 milligrams per kilo total.
What would the rest of your anesthetic look like?
I typically do a multimodal analgesic regimen, especially for these major spine patients. In our group, we would typically include ketamine, occasionally some Precedex, and then of course methadone, in addition to all the other non-opioid medications as well, such as for us in the United States, it's Tylenol and even ketorolac for our ortho patients.
Would you use any other opioid with methadone in this context?
We try not to unless it's post-surgical. So intraoperatively, if we're going to choose methadone, which is part of our ERAS protocol, we will stick with methadone and then try to supplement methadone at the end, depending on pain scores by the patient or respiratory rate. And then once the patient goes to the floor, then our pain service takes over, and they usually will convert to as needed IV hydromorphone.
So just drawing a little bit of attention to Stephanie's particular point about not using other opioids and potentially other drugs like benzodiazepines. This is quite an important point, and we'll go over this in a bit more detail later on in the talk, particularly in the context of a number of adverse events that were reported to our largest database, WebAIRS, and very kindly shared with us by Yasmin Endlich and analyzed by Emily Jarizva. So the next data essentially explores factors that influence methadone dosing. So by far, the single largest thing was the type of surgery and the expected stimulus, fairly logical, age of the patient, opioid naive versus tolerant. Dosing for opioid naive patients, if ideal body weight or total body weight was used, typically tended to be between sort of 0.2 milligrams per kilo and 0.15 milligrams per kilo.
This is a fairly long video, but I thought it was worthwhile watching. It goes through how Evan does his dosing and makes his recommendations.
How do you dose your methadone? This is a common question, certainly in practitioners who are hoping to start out using methadone more in their practice. They often ask, how would you dose methadone for this person having this surgery?
I'm going to give you the very simple, short answer first, and then I can go into a little bit of detail. I'd suggest 10 milligrams. Now, here we're talking about adults, okay? And children are a little bit different, but let's talk about adults. Adults, we're talking, to make this very simple, 10 milligrams for same-day discharge surgery, 15 milligrams for next-day discharge surgery, 20 milligrams for inpatient surgery, and probably closer to 30 milligrams for major spine surgery, multi-level major spine surgery, because those patients really hurt. Now, what lies behind that is, first of all, the seminal papers that came out of Australia in the 1980s, done by Jeff Gourlay and colleagues, where they gave 20 milligrams of methadone to everybody. Now, back then, almost all the cases were inpatients. This was a very wide variety of surgical procedures, but they just gave 20 milligrams to everybody. And a third of those patients went home needing no more opioid at all. A third of them went right to oral opioids, and only a third needed some supplemental intravenous opioid. So that 20 milligram dose worked very well, and I have taken my cue from that study. My own clinical experience in doing major spine surgery and in talking to my colleagues as well is that those patients typically do need more, in part because it's such an extensive operation and so painful. You may also lose a little bit of it because of blood loss. In outpatient surgery, we did studies where we did dose-finding studies in same-day discharge patients and next-day discharge patients because we wondered if the dose might be different than the dose for inpatient surgery, thinking that, well, maybe outpatient surgery is a little less painful. And when we did these studies, we dosed to ideal body weight. And the reason we did that is the problem of obesity in America. And when we talk about dosing to weight, the question is, well, which weight do you use? Do you dose to ideal body weight or do you dose to actual body weight? Well, we have some patients whose actual body weight may be 3 times greater than their ideal body weight. And so when we did the studies, we dosed to ideal body weight. And what we found was that for same-day discharge surgery, a good dose was 0.15 mg per kilo of ideal body weight. And now that's conservative dosing. But since all those patients had approximately the same ideal body weight, that comes out to about 10 milligrams. And since most of us can't calculate ideal body weight when we're standing at the head of the bed in the operating room, it's just much easier to tell people, give 10 milligrams. Now, for next-day discharge, those patients needed a little bit more opioid because those are more invasive procedures. And we learned that the ideal dose was 0.25, maybe 0.3 milligrams per kilo. But again, being conservative, that comes out to about 15 milligrams. So I tell people for next day discharge surgery, give 15 milligrams. And we know that after 10, 15, and 20, patients will breathe and they'll wake up mostly comfortably. Now, the other thing that we keep in mind is that that's conservative dosing. Some patients may need additional opioid in the recovery room. And for the patients that we give methadone in the OR, we give them methadone in the recovery room for the exact same reason, because we want them to have good long-duration analgesia. In the recovery room, our typical dose recommendation is 2 milligrams every 5 to 10 minutes for moderate to severe pain, up to maximum of 6 milligrams. And after that, we want the recovery room nurse to call the anesthesiologist, because we know from our experiences that 2/3 of the time, 6 milligrams takes care of everybody. A small percentage of patients may need more, but we just want to go and evaluate them to make sure that it's really pain that the nurses are treating. Sometimes patients can be extremely uncomfortable because they can't empty their bladder. Well, no opioid is a cure for urinary retention. So we want to make sure that we're doing the right thing for the right reason. So 10, 15, and 20, and up to 6 in the PACU.
Thanks so much, Prof. And one other question, when do you normally start giving your methadone? So there's again a range of practice here. I know some practitioners who will wait till they induce and only after induction do they start giving methadone. When I give methadone, I normally place the IV and start giving the methadone, because I find that titrating it in an awake patient gives me an idea of how sensitive they might be to methadone.
Mhm.
How do you give your methadone?
I typically will give it as the first drug I give as part of an induction protocol. So I'll get patients in the operating room, and very often while I'm putting on monitors, or the first drug that I give after I've put on monitors, will be methadone. And I'm doing 10, 15, or 20. I'm not titrating. You are very correct that titrating opioids will give you an indication of how, quote, sensitive a patient might be. And it does predict post-operative analgesic needs because it shows their degree of sensitivity. I tend to go with fixed dosing, 10, 15, or 20. And I do it as part of induction.
This is the paper that was just referenced by Dr. Karash, and we do have Jeffrey Gawley here with us as an honored guest tonight. And so we'll just go through his seminal paper here, which was published in Australia. So 20 milligrams of methadone was given to patients post-induction, and this was a combined clinical and pharmacokinetic study where plasma levels were measured. And as you can see, there were 3 groups. The first group needed no additional analgesic requirements up to 72 hours post-operatively. And some of them were having big operations. It's worth noting that at this time, there was no lap chole happening in Australia. The first lap chole happened many years after this, so they're all open. The second group had pain analgesic request, a median time at 26 hours, and that was for non-opioid based analgesia. And the plasma level at that time was a mean of 31.5 nanograms per mil. Then the third group requested IM opioid analgesia, median time to request 20 hours, again with a mean plasma level of 31. As you can see, that's 7 anterior spinal fusions. These are big operations. For them to not need pain relief up to that time is reasonably impressive. They did find that the terminal half-life did positively correlate with patient age. So that's where the numbers that people talk about for 30 nanograms per mil as the threshold for analgesia originates from. Dr. Gawley, given that your papers have been the prompt for so many people to actually start using methadone and investigate methadone, I was wondering if you might be able to share with us what your original reason for starting to use methadone yourself was.
Sure. It was quite interesting. I moved down to Flinders in the late 70s and basically was looking at the organ toxicity of volatile anesthetic agents. During that time, people were doing, Laurie Mather's group were looking at sort of constant rate pethidine infusions. Basically, I managed to transfer to the pain unit, and I was looking for a new sort of idea, a new area where we could look at ourselves. And because the Mather group showed that constant blood levels resulted in much better analgesia compared to intermittent intramuscular injections. A literature review which suggested that methadone might be an option. It's not going to be absolutely constant, but the blood levels are not going to fluctuate to that degree. So it was a matter of convincing some anaesthetic colleagues to try a drug that they didn't normally use in the treatment of pain control. And basically, it was easier to use. We didn't need an infusion pump, and the rest is history, really.
Thank you very much for sharing with us, Dr. Gawley. So we have another poll here now. So when using IV methadone, what opioids do you use to blunt laryngoscopy response where necessary? And we're wondering if Prof. Lawrence could maybe speak to, Lawrence Weinberg could speak to what he thinks about the response to this one.
Yeah, thanks, and congratulations to everyone hosting the meeting. Yes, I don't have any strong preferences, but certainly would use an opioid. Usually any of the opioids listed there. So 10 to 20 mics per kilo of alfentanil, which has an equianalgesic dose of around 0.1 to 0.2 mics per kilo of remifentanil, ideal body weight, 1 to 3 mics per kilo of fentanyl, and again 0.1 to 0.2 milligrams per kilogram of oxycodone. I would use very comfortably in select patients if I was using IV methadone.
I think most people would agree with you, Lawrence. So most people do use alfentanil. A large portion still tube on methadone. And it'll be interesting to see whether there's been any issues with that, because I can imagine the timing and the dose would be quite hard to achieve. We might come back to that one a bit later just for the interest of time. And we'll go on to the next poll.
So our next poll is, if IV methadone was given intraoperatively, what IV opioids, if any, do you typically prescribe for PACU use? And we were hoping to ask Tony Anderson what you do in terms of your PACU dosing following methadone usage.
There's what I do and what I'd like to do. And those are unfortunately two very separate things that are somewhat determined by things in the PACU that are often beyond my control. So I would prefer for inpatients to give 0.05 mg per kilo of methadone times 2 PRN in the PACU and not give additional opioids. However, at our institution, that requires an anesthetist to give it. And so if I'm covering a room solo, that's just not possible unless I can find a colleague to do that. So then I would resort to our standard weight-based PACU order set in the electronic medical record that include fentanyl for moderate postoperative pain and morphine or hydromorphone for severe postoperative pain.
Thank you very much for sharing those thoughts.
This is a protocol that was very kindly shared with us by Professor Revan Karash from the Duke University Hospital. And I think most of us are starting to become quite familiar with the inpatient surgeries getting 20 to 23-hour observation or overnight stays getting 15 and same bed discharges getting 10. But what I found particularly interesting about this was so just looking under the inpatient surgery box, bigger cases such as major spine, so multi-level fusion, scoliosis corrections getting 30 to 40 milligrams, which is a fairly high dose by most standards, but obviously being used safely. And the other part of this paper, this particular slide that's quite interesting is the concomitant medication section. So just near the bottom, with the suggestion that little to no other intraoperative opioid be used. Sedative hypnotics that could potentiate the opioid-induced respiratory depression of methadone also be avoided. So drugs like gabapentinoids being withheld, sedating antiemetics such as droperidol, cyclizine, benzodiazepines. It is quite interesting in that a lot of practitioners who do have a lot of experience with methadone still seem to use it quite safely, but certainly the other drugs do warrant caution. And this was once again reproduced quite interestingly in a lot of the adverse outcome data that we've been able to collect around methadone in Australia. Once again, I'd like to perhaps draw on James Sear just to ask, would you agree largely with the dosing strategy here, in particular the higher doses for bigger cases?
Yeah, I definitely would. And I kind of mentioned in the chat, actually, I direct our pediatric bariatric surgery program in which many of our patients who are under 18 and have weights, ranging from 120 to 160 kilos, we actually use adjusted body weight and 0.2 milligrams per kilo of IV methadone, which frequently results in, 15 to 25 milligrams as a total IV bolus. And so even though these laparoscopic gastric sleeves aren't typically the same as like a big spine case, in using this dosing strategy, it allows us to obviate the use of further opioid in the post-operative period. When we weren't using methadone, a lot of these patients would end up getting large doses of oxycodone during their first and second post-operative day. But we've now shown that the patients who receive this large dose of IV methadone intraoperatively don't get any opioid in the post-operative period, which is actually more ideal, especially for these types of patients who will be less monitored when they receive opioid post-operatively. And so this dosing strategy that Dr. Karish has shared mirrors that in the patients that we're taking care of.
Yeah, fantastic. And James, what are your views on the concomitant use of benzodiazepines and other potentially sedating agents with a methadone-based analgesic strategy?
Yeah, ideally you would try to avoid it, but sometimes, especially for our spine patients, when muscle spasm is a consideration in the postoperative period, our pain service does sometimes use a low-dose benzodiazepine to try and address that. But knowing that a patient has received methadone, you may try a lower dose benzo to avoid concomitant respiratory depressive effects of both. So typically, our first line is to use other muscle relaxants if possible. Our pain service uses drugs like methocarbamol, which brand name is Robaxin, and that also does have some potential sedating effects, but not quite the same synergistic effect as benzodiazepines do with opioid.
So I might call on Kez or Jane to comment on this initiative by Epworth. So I thought it was one of the really practical initiatives introduced to highlight when IV methadone has been given intraoperatively. It's quite similar to the one that most hospitals would use for intrathecal morphine, and I think it's a great idea. It immediately alerts the staff that methadone has been administered during the case, and it does serve a reminder to exercise caution when you're using oral opioids or other CNS depressants in the post-op period. I wonder if any other institutions have implemented anything similar to this.
So we developed this after we had a pediatric patient who had a McCall due to methadone, and I think the nursing staff spoke to the surgeon and were given other opioids to give, which then resulted in the patient going back to ICU once they got to the ward, once they were given additional analgesia. So we decided that it needed to be really a flag or an alert for the nursing staff to be aware that this patients to be given methadone, that what else could they be given. So this is kind of based on the same theory as intrathecal morphine. So we have just, I guess, changed it slightly.
Thanks, Kez.
So in the survey, anaesthetists were asked what they wanted for their methadone patients postoperatively. 60% didn't want anything in particular. 5% wanted increased respiratory monitoring and HTU being available as a matter of course. And 25% roughly would like that where possible.
We've got summary slides just to highlight the key points. So this is the summary of the systematic review level evidence, essentially supporting the view that methadone versus other opioids reduces postoperative opioid consumption for up to 72 hours post-op, while still reducing the pain scores separate from that, and critically decreases the pain scores on movements up to 72 hours post-operatively, and does increase patient satisfaction as well, all the way out to 72 hours. And it does not increase the opioid-related respiratory complications, cardiac complications, or PONV. So this is a large meta-analysis that looked at 14 RCTs, 900 patients, and essentially there was no difference in PACU statistically, but on opioid consumption at 24, 48, and 72 hours, there was a statistically significant, and I would say clinically significant difference, because this is IV morphine equivalence. It's not oral morphine equivalence. So it's a significant dose reduction. And this is the forest plot that essentially delineates that. So PACU, no difference, and up to 72 hours post-op favors methadone. Similarly, so this is pain at rest and at movements at 24 hours, again on the forest plot favoring methadone, and I'd say clinically significant pain score differences as well. And this is 48 hours, 72 hours, again, all favoring methadone. And this is the secondary outcomes that we briefly mentioned. So no difference in POMV, no difference in respiratory adverse events, no difference in cardiovascular complications, and significant increases in patient satisfaction favoring methadone, which is again shown on this forest plot. This is another separate systematic review as well that again essentially supports the same findings that in heterogeneous surgeries of all types, methadone does decrease postoperative opioid consumption. And essentially this is just the summary of that meta-analysis. And critically, there does not appear to be an increased risk of opioid-related side effects, particularly for respiratory depression and sedation. However, they acknowledge in this that safety-powered trials need large numbers and that these are relatively small RCTs granted combined give a large number. And this is just another RCT that, again, is tagged there that you can look through in your own time that essentially shows that methadone decreases postoperative opioid consumption, which is displayed in this bar graph here. So we've got another snippet here as well, short 1 minute.
Point your listeners to a couple of extremely well done and well written clinical studies. These were both led by Dr. Glenn Murphy, an anesthesiologist in Chicago, Illinois, in the States. He's in private practice, but he's one of the finest, most meticulous clinical investigators who I know. He did 2 outstanding studies. He did one comparing methadone to hydromorphone for major spine surgery. And he did another study comparing methadone to, I believe it was fentanyl, for cardiac surgery. And the outcome in both of those studies was that the patients who got methadone used less postoperative opioid, they had less postoperative pain, they had no difference in opioid-related side effects, and their satisfaction scores with their anesthetic experience were much higher if they got methadone compared to either of those 2 other opioids.
All right, so just moving on to a summary of the spinal surgery articles. In adults undergoing multi-level spinal surgery, when methadone is used intraoperatively, essentially post-op opioid consumption is reduced, patient satisfaction is increased, pain scores are decreased, and again, particularly they're decreased on movement. In adolescents undergoing complex scoliosis surgery, when methadone is incorporated as part of a multimodal analgesic plan, even length of stay can be reduced, and that has significant health economic implications. And again, there were no increases in opioid-related adverse events. I note in the chat there's a discussion around the power of studies, and we will get to some more higher-powered studies for safety a little bit later on as well. So this is that trial that Dr. Crush mentions in his chat just before. So this is methadone versus hydromorphone for multi-level spinal surgery, and found that when methadone was used in place of hydromorphone, and they used actual body weight for this, so it's relatively high doses, but they found lower pain and no increase in complication rates. And there was no difference between other minor side effects such as itch, nausea, or vomiting as well. And this is another study looking at posterior spinal fusion. So this is in adolescents undergoing major spinal surgery. So they're, 14, 15-year-olds. I think importantly of note here, they're having massive surgery. So they're having 13 levels fused at the one time. And this is an interesting study because they changed the whole protocol. So none of this can be directly attributed to methadone. It's worth reading the trial if you're interested, but they did incorporate methadone as part of their multimodal change. And they did have some quite impressive outcomes, particularly shortening length of stay by an entire day, which they estimated as saving approximately $10,000 US back in 2020. So feel free to go through some of these studies in more detail in your own time. Unfortunately, we just don't have the time tonight. And this is another RCT, again, looking at complex spine surgery. And again, finding that when methadone is used, there is a decrease in postoperative opioid requirements. If we look at the safety assessment of methadone, which I think is everyone's key concern, I think rightly so, methadone, it does not appear to be associated with an increased rate of opioid-related adverse events. Some studies have suggested a lower rate of things like PONV and sedation, but this has not been consistent. The risk of things like QT prolongation resulting in ventricular arrhythmia in the perioperative setting is essentially unheard of. As has been mentioned a few times previously, the risk of QT prolongation is essentially isolated to opioid replacement therapy in the community on long-term dosing with high dosing in the community as well, at least 100 milligrams daily. And most of the data and case reports showing QT prolongation events are actually on patients in the range of 300 milligrams daily. The risk of serotonin syndrome appears to be extremely low. However, we should still display caution when considering dosing in patients on other serotonergic drugs, particularly things like classic monoamine oxidase inhibitors. So this is a study that was published in March 2025, so quite recently, and this is a Danish paper. So it's a retrospective cohort study, but they looked at morphine versus methadone retrospectively, and they actually looked at a lot of patients. So they looked at 14,500 patients. 2,500 of these approximately had methadone and 12,000 had morphine. And there was no statistically significant difference in the administration of naloxone. And I think based on the numbers that Stephanie was throwing out earlier, this is the paper that she was referring to in terms of the safety profile of when these patients received naloxone. And I think that is worth noting that in the methadone group, these patients received naloxone all in OT or in PACU, so in a highly monitored environment compared to the morphine patients, which had a longer time to requirements of naloxone, some of which occurred on the surgical ward in a lower degree of monitoring environment. And on first principles, at least, I feel like it would be reasonable to state that that's a more risky context to need naloxone in than needing it in PACU. There was no difference in the number of boluses required, and all the patients improved clinically. And so they looked at the secondary outcome of PACU length of stay here, and the methadone group was longer. However, it should be considered in the context of the group receiving methadone. And to qualify to receive methadone at this hospital, you had to meet certain criteria of being on chronic opioids with an OMED of at least 60 milligrams, and to have had a previous incident of severe postoperative pain, or to be having a very large surgery. And despite this being a higher risk cohort, there again was no difference between the administration of naloxone between these groups. So this is just more data on the naloxone administration pattern for these, which essentially just in table format goes through what I've mentioned. So as part of the safety profile, we're all concerned about the potential adverse effects and drug interactions of methadone. And as we said, it's essentially a multimodal analgesic in its own right. So it has a risk of interactions with other things, particularly serotonin syndrome in combination with other drugs. Cardiac arrhythmias, hopefully we've already safely discussed, and OIV we've touched on. So this was an expert opinion piece on the considerations of anesthetics and classic monoamine oxidase inhibitors, which is the non-selective and irreversible monoamine oxidase inhibitors. And so if you look at this table here, and what I've kind of summarized to the right of it, talks about the opioids and their risk of serotonin toxicity. And whilst methadone has a potent serotonin reuptake inhibition potency, at clinically used doses, it's actually very safe, and the risk of causing a serotonergic toxicity is very low, and certainly much, much lower than pethidine and tramadol. So essentially, just to describe what serotonin toxicity is, obviously the syndrome is a spectrum. The toxicity is when the level is greater than 100 times of the baseline intrasynaptic serotonin level, and that is far more likely to occur in the context of multiple drugs being combined together in their mechanism of action. So the likelihood of getting it with drugs that are just causing SRI activity, so something like fluoxetine and methadone, is much lower than if you combine classes together. It's important to remain wary of this overall, and one of the takeaways from this article as well is methylene blue is actually a potent monoamine oxidase inhibitor. So maybe the patient who's getting lymphatic dye testing with methylene blue is not the one to give methadone to, just something to keep in mind. So this is, again, just looking at WHO Vigi-based database showing reporting of suspected serotonin toxicity and the correlation with methadone. And you can see that this is data over decades, and that's only 5 cases of serotonin toxicity were thought to be methadone related. Obviously, as well, I would like to acknowledge the frequency of use bias for methadone compared to the other agents, but that does suggest that it is a very rare event overall. We might skip this video for time's sake. Essentially, it just says that Dr. Karash is not particularly concerned about the risk of serotonin toxicity and that he has not encountered it clinically.
Just touching briefly on this particular study, this study explored the genetic polymorphism of 2C19, which is a subset of the cytochrome P450 enzyme. and what that might have meant in terms of side effect profile and plasma levels of methadone. It was quoted in the APMSE book in the context of cardiotoxicity, and the QTC was certainly found to be prolonged by an average of 12.7 milliseconds plus minus 25. However, this was only really found to be the case when plasma concentrations were over 150 nanograms per mil. The most important feature here is that for moderate to severely painful surgery, when used intraoperatively as an intravenous single dose or a temporarily repeated dose in the postoperative care unit, we're only really aiming for 55 to 60 nanograms per mil, as that's found to be quite effective. We really need to get to levels that are 3 to 4 times what we're normally aiming for to start to see those effects in a clinically significant way.
And this is, again, just another review looking at methadone and essentially saying that the risk of QT liver prolongation is very rare in the context that we're talking about. So this is that trial I mentioned before. Essentially, this is it's a retrospective study. It was a very high-risk cohort, and there was no propensity-matched group. And so they had a finding of high rates of opioid-related complications, where if you look at the preoperative analgesic use rates there, they're very high in terms of the context of risks. If we look at the intraoperative data as well for these patients, they were getting very large doses of hydromorphone added to their methadone dose intraoperatively, which, as we've discussed, is probably not something that anyone's recommending. If you look at the range here, some of the patients were getting wild doses. So one patient got 350 milligrams equivalent IV opioid intraoperatively. And if we look at, the adverse events postoperatively, yes, if you look at these rates, they look bad. They're quite high. But if you actually look at it for spinal surgery rates of complications in general, which we can see in another trial called by Scuba et al., they actually match up. And that trial didn't include methadone patients. It was just the risk of having major spinal surgery. And these complication rates correlate with that quite nicely. And so, as we've kind of discussed, it's, a high-risk cohort that's not propensity matched, that had complex pain requirements preoperatively. They all had a planned admission to ICU, which I think it's fair to say would alter most of our dosing. And this is just another slide to show the high amount of hydromorphone they were getting postoperatively. Kind of 30 to 50% of their dose was only methadone, and the other 50 to 70% was hydromorphone. So this is another, it's again retrospective, but they looked at close to 30,000 records for naloxone use. Only 26 out of the 29,300 got naloxone. There were 340 methadone patients. And again, in keeping with the previous retrospective data we've found and the prospective data, there's no statistical difference between the rates of naloxone administration between methadone and other opioids. I would like to acknowledge here that obviously administration of naloxone is a very blunt tool for the capture of data, but it is difficult to find a level of nuance beyond that. And this is what we're left with. We would like to move on to some local data now, just to go through.
Yeah, some stats were performed at the point where 500 of the 700 responses had been submitted. And what we found there didn't appear to be a relationship between reporting of adverse events from respondents and the dose that they were giving. However, we did find that respondents who reported using adjuvants alongside methadone, such as midazolam, specifically midazolam, oxycodone, fentanyl, clonidine, or dexmedetomidine, were substantially more likely to report methadone-related respiratory adverse events with a fairly high degree of confidence.
This is just a survey of adverse events from our respondents that shows, relatively low rates overall.
Harsh, you share the WebAIRS analysis.
Sure. Thanks, Sarah. So WebAIRS, as most of you know, is the largest adverse event reporting database across Australia. And we're very fortunate to have Yasmin Endrick, as well as Emily Jarsimha, who shared methadone-related adverse event data with us for analysis. They'll obviously be publishing their own analysis of this data completely independently. From what we saw, there were 17 reported adverse events where methadone was a part of the anaesthetic. Of these, 7 were unlikely to be methadone-related, as they included things like anaphylaxis to rocuronium, residual paralysis, which improved when objectively assessed using a twitcher and with reversal administration. The themes that we commonly saw was adverse events associated with a poly-opioid technique, so frequently mixing methadone with non-ultra short-acting opioids, so fentanyl doses that were high, so greater than sort of 150 to 200 mics, occasionally 250 mics, drugs like oxycodone, early benzodiazepine and sedative use. So the use of 1 to 4 milligrams of midazolam was quite common, and other sedative agents that acted in synergy like droperidol, as well as longer-acting alpha-2 agonists like clonidine seemed to be present. Gabapentinoids were present in 2 cases, and the dosing for these patients was fairly high, up to 600 milligrams, just to draw attention to the fact that there is an FDA black box warning around the potentiation of general opioid-induced respiratory depression in these patients. Certain centers do practice pausing these drugs for 24 to 48 hours and restarting them 24 to 48 hours post-operatively in the setting of methadone use, which could be something to consider. Timing of methadone was also a key factor, with dosing late in the case being associated with more adverse outcomes. And often these patients had been maintained on a remifentanil heavy anesthetic as well, which, when turned off, obviously required larger doses of rescue opioids with potential opioid stacking and recovery. There were a number of arrhythmias that were reported as being associated, arrhythmias such as rapid AF and complete heart block, which are not usually consistent with methadone's pharmacology, were reported. We also did notice significant documentation gaps and very variable naloxone responses, in particular in patients that were co-administered benzodiazepines, where naloxone was given but with minimal impact on the patient's sedation and respiratory rate, which suggests perhaps a more benzodiazepine-heavy cause for sedation. So the next few slides go over a small cohort of surgical feedback. So this is by far not high-quality evidence, and we are working on something a little bit higher quality in the future. So we interviewed a small group of surgeons where their anaesthetists, largely in private practice, did use a significant amount of methadone in their practice. So we found, first of all, for painful operations, so half of these surgeons were cardiothoracic surgeons with a specific interest in thoracic surgery. The other group comprised of spine surgeons, also heavily involved in the chronic pain cohort, and lower limb arthroplasty surgeons, particularly people that specialize in knees. We found that SR opioids were prescribed very routinely for up to 2 weeks on discharge. This was a somewhat concerning thing to note, given the stewardship that we've introduced within our country. So in 67% of the cases, long-acting opioids were prescribed for up to 2 weeks. Now, most of these surgeons, at least 50%, encountered methadone being used in their patients in the perioperative setting. In this particular area, these surgeons found that in 67% of cases, the analgesia was noted to be much better than alternative techniques. In terms of sedation, this was quite surprising to us. So these surgeons actually reported a lower incidence of adverse events such as sedation. Typically, PCAs weren't used post-operatively. It was mostly oral analgesia, and they found their patients to be sort of quite happy, quite lively, and quite awake. Considering surgeries where patients required substantial opioid prescriptions on discharge, we did ask whether they'd noticed those who received intraoperative methadone to require fewer or no opioids post-op. A small cohort consistently found this to be the case. The others were a little bit less sure, as often their post-operative prescribing was delegated to either a junior medical staff or the regional medical officer or the GP.
Thanks, Harsh. So just following on from that, there's a section, some studies look at community outcomes. So intraoperative methadone appears to have an effect beyond the 72 hours of duration, with outcomes in differences in the community for up to weeks and months post-operatively, including decreased pain scores, decreased opioid consumption, and decreased health provider contacts for pain management. The mechanism of this is unclear, but it's probably linked to a combination of factors, some of which might be acute pain control post-operatively, decreasing the progression to chronic post-surgical pain, as well as the multimodal nature of methadone as well. And so this is that spinal surgery that we mentioned earlier. They did a pre-planned analysis to do a long-term follow-up on these patients at 1, 3, 6, and 12 months, looking at the frequency of pain and the severity of pain post-operatively. Essentially, the spinal surgery, methadone versus hydromorphone for multi-level spinal surgery, showed a significant decrease in frequency of pain at 3 months, with methadone being less than once a week versus daily for the hydromorphone group, and that was statistically significant. Back pain with movement was less as well at 3 months, and the use of opioids at 3 months was 10% with methadone versus 41% in the hydromorphone group. There were no differences in longer-term follow-up. The cardiac group, there's less dramatic differences. Out to the first month, there's a little bit of a difference, and then beyond that, it's not as significant. But I would just like to draw people's attention to this, where a lot of spinal surgeries are performed for pain management. That is the indication for the surgery. And this is an anesthetic technique modification that can be used to alter the surgical outcome, which I think is really critical to think about. I draw the parallel to using TIVA for onco-anesthesia. The number needed to treat for that to be effective is quite high. Whereas looking at this data, there's some pretty strong evidence that we should be using methadone to improve patient outcomes for multi-level spinal surgery. And I think also, if you look at that difference in opioid consumption in the community, and flowing on from Harsha's data about the potential change in discharge prescription following the use of methadone for patients, we know that there's good data to say that there's iatrogenic opioid harm associated with volume of discharge and duration of discharge dispensing post-operatively, and that there is the potential that this carries significant community morbidity and mortality reduction, and that hopefully someone does more studies on this to look into it in detail. And essentially, that's what this piece talks about, is the use of perioperative opioids in the era of the opioid crisis, and that currently there's no data linking intraoperative opioid use and community opioid tolerance and dependence. As I just said, there is data linking the discharge volume, and potentially the use of methadone will decrease the discharge volume. So again, just bariatric surgery, there are a few studies. Bariatric is a population that some people are concerned about. Basically, in open or laparoscopic bariatric surgery, compared to fentanyl and morphine, methadone improved pain, decreased opioids, improved satisfaction, decreased PONV, and decreased sedation, which is quite interesting. So this is an RCT looking at open bariatric surgery, methadone versus fentanyl. And essentially, this is the one that found that there was actually a decrease in PONV rates compared to the other opioid used. And this also looked at evoked pain at 3 months, and there was a reduction in that. And this is looking at laparoscopic gastroplasties, which was sleeves or Roux-en-Y bypasses. And again, found that methadone had improved outcomes compared to morphine. So this is a really interesting study, which talks about the sensitivity of patients with OSA treated or untreated compared to people without OSA to opioids. And essentially has the data from this, obviously it's a very small trial, but it does potentially challenge a fairly long-held concept that patients with OSA are intrinsically more sensitive to opioids and they should receive less opioid, because this found no difference between these three groups of treated and untreated OSA compared to people without, in terms of end-tidal CO2, ventilatory rate, pupil area, or sedation, or response to pain on a ramped remifentanil infusion. So it's just something to consider, and that hopefully more data will come out looking at this, because that is a cohort that is at risk of pulmonary complications. So this is just looking at when people would avoid methadone. And as we've just said, OSA is a significant consideration for people. So we've just got another poll here as well. So following intraoperative IV methadone, what do you usually prescribe for post-operative analgesia on the ward?
I might call on one of our experts who has given IV methadone. What would you normally prescribe for your post-op analgesia? I might let you kick off first, James.
Yeah, in the post-operative ward, for example, for our spine patients, we previously were prescribing hydromorphone PCAs, but we've actually found that with more consistent use of methadone, we actually get them off the PCA by post-op day 1 with PRN oral oxycodone. For, as I alluded to earlier, the pediatric bariatric surgery protocol, we actually don't give them a PCA after laparoscopic gastric sleeve. And so it really depends on the pain, the anticipated pain severity. Our pain service is typically not afraid of putting them on hydromorphone PCAs, but typically they will underdose, knowing that the patient has received intravenous methadone intraoperatively.
Thanks so much, James.
The slide just shows there is an evidence base for day case in ambulatory surgery, but if an appropriate dose is given, it does appear to be safe. Pediatrics, which James has alluded to in the bariatric context, there is a role for methadone. It is evolving. Spinal surgery and NUS procedures seems to be the main thing. There is potentially a role in other procedures. I think Stephanie mentioned tonsillectomies. So hopefully more data will come out in that context. There is a role potentially in obstetrics for the GACs population as well. It's small numbers, the data that there is there. That's in keeping with the fact that GACs is a relatively uncommon event and is often time pressured emergency. So it's hard to get large volume data there. This is just to show that the Royal Women's has data that says that essentially methadone is considered safe to use in breastfeeding, and that's from the oral opioid replacement dosing. It's much higher than perioperative dosing. There doesn't seem to be heaps of data about ERAS yet. It's probably coming, but as we've talked through, it does tick a lot of the ERAS principles, essentially. So again, it's worth considering in the ERAS context as well. Most of the pieces on ERAS are opinion-based interpretations of data at this stage.
Yes. So I think we want to touch a little bit on the anesthetic techniques and adjuncts. And from our survey, we did show that most people would use ketamine, as it's shown to have a synergistic effect with methadone. And quite a substantial number of people are still using fairly large doses of fentanyl and, of course, midazolam. Now, we might skip through, but one of the things to highlight is this FDA warning about the use of gabapentinoids, so something that people may not be so aware of.
This is an upcoming trial that is likely to be published in the near future that Dr. Karash mentioned in that previous snippet, which hopefully people can keep a lookout for. This is a survey done at the time that we thought we would be presenting dexmedetomidine at the same time as this. I think the thing that is really promising and encourages me as a registrar and a trainee is that so many people are open to trying new things and evolving their practice. And it's really great to see that, given the percentage of our respondents the vast majority were consultants, that 41% were definitely keen to try methadone or dexmedetomidine and see if they could fit it into their practice, and another 48% were open to it. And I just think that is a really great reflection on the practice of anaesthesia in Australia, and that we're willing to evaluate evidence and evolve our practice as things change.
Just on a concluding note, and looking at some of our, I guess, reflections from working through all the evidence, from talking to experts, and from, I guess, presenting everything here, it would be worth just going over how we might be able to use methadone safely in our practice. And at various points, I might ask our experts from the States to perhaps chime in. Now, to start with, I guess, the dosing summary, so using 0.15 per kilo for short, perhaps a day or short stay cases, all the way up to 0.3 milligrams per kilo by lean weight for larger cases can safely be done. And they're all evidence-based and depend on the nature of the surgery. The timing of the dose itself is quite important. So keeping in mind that the peak effect is between 8 to 12 minutes of administration, and the distribution within 30 to 45 minutes does lend itself well to the resumption of spontaneous ventilation and a respiratory drive. Titration in the anesthetic bay might be one consideration that people might want to incorporate into their practice. So giving a few, 3 to 5 milligrams at a time up to a dose that might be considered somewhat appropriate for the procedure that the patient's about to have, just to see what the response is in a monitored environment with anaesthetist oversight. And particularly what to be careful with. I think it's important to, when giving a methadone-based anesthetic, to try and keep it methadone-based. So avoiding regional might be a thing to take away. So maintaining some level of pain stimulus that methadone can actually counteract. Considering the use of other opioids, so considering using things like small doses of alfentanil or remifentanil for intubation and blunting the sympathetic response to intubation, and considering a very well titrated maintenance anesthetic, so using depth of anesthesia monitoring like Masimo, Entropy, or BIS, considering strategies that may spare larger volumes of hypnotics being administered, such as a high TCR targeted propofol infusion over the course of many hours. So drugs that can potentially spare propofol, obviously maintaining safety and minimizing the risk of awareness. So things like Incan infusions with a consistent context-sensitive half time of 20 minutes turned off well before the end of the case, or remifentanil. Care with drugs like clonidine that have a longer duration of action, perhaps a small role of something like dexmedetomidine administered early, allowing for offset. And considering, once again, to re-emphasize depth of anesthetic monitoring, because if we are reducing the hypnotics that we're using in order to make sure that at the point of intubation, there's minimal hypnotic on board, whether it's volatile or propofol, then depth of anesthesia monitoring is absolutely critical. It's also worth considering that if administering methadone in recovery, that we really do need senior medical staff oversight, as nursing staff, especially in Australia at this point in time, are not too familiar with the drug. So perhaps if we are giving 1 to 2 milligrams every 5 to 10 minutes, that there might be a review dose, perhaps at sort of 4 to 6 milligrams, and post-operative monitoring, potentially naloxone orders, and greater education and training around the ward, and some level of, I guess, flagging of patients that might have received a dose of methadone, such as with stickers that have been implemented by both Ramsay across some sites and Epworth.
Ash, I might play the recording of a 3 minutes long where Professor Koresh actually talks about anesthetic technique, because I think your comment about, methadone and the use of Neuraxil could have thrown some people off, because that's not a very known thing.
Talking about anesthesia technique, is the use of methadone in patients who are having Neuraxil analgesia, whether it's an epidural or, spinal. Do you also tailor that dose, given that the surgical stimulus might be slightly different now?
Wonderful question. I don't mix methadone and needles, so to speak. I don't give methadone to patients who are having a regional anesthetic. I don't give it to patients who are having a neuraxial anesthetic. And it's for a couple of reasons. One is we just don't know what the dose is in those patients. But if we think about this, we use opioids to counteract pain. We use pain to counteract opioid-related side effects. Well, if we have a patient and we suddenly take away their pain with a neuraxial anesthetic, now we have no pain but unopposed opioid side effects. And that's something that we want to avoid. And I'll just share with you something that happened several years ago. I'd mentioned that I'd made a visit to Sydney a few years ago and gave a lecture on methadone. And a few years after that, I got a telephone call from Australia, from a practitioner. And he said, "Dr. Karish?" I said, "Yes." He said, "I was in the audience when you gave your methadone lecture, and I've been using it ever since, but I wanted to call you and tell you something." I said, "Okay." He said, "I do all of my total shoulders with a dose of methadone, because if we do it with the block wears off, patients are painful, they're unhappy. I do it with methadone, it lasts for a few days, and they're extremely happy." Well, I did a case the other day. I gave the patient my usual dose of methadone, and then for some reason at the end of the case, the surgeon put in a catheter and attached it to an on-cue pain ball and woke the patient up. The patient was very comfortable. We took the patient to the recovery room, and after about a half an hour or so, the surgeon stopped by and turned on the on-cue pain ball to start infusing local anesthetic. And suddenly the patient got very drowsy and their respiratory rate dropped to 6. Well, this is the exact example of what happens if you suddenly lyse the pain. You have unopposed opioid side effects. So yet again, most of what I've learned about methadone, I learned from the Australians.
We'll do a closing with another video from Professor Koresh.
Advice would you give the practitioner who's very keen to start using methadone in their practice, not very familiar? How would you advise them to, and I know you mentioned the doses, 10 milligrams for day surgery, 15 for next day discharge, and 20 milligrams kept for slightly larger procedures. Are there any things that you would really like to emphasize to these practitioners who are just starting out, really keen to start incorporating methadone into their practice?
Yeah, I think that like anything, most of us had to do something for the first time, sometime. The doses that the 10, 15, and 20 are conservative. There are people who use higher doses, but I wouldn't jump in using those higher doses. And if people want to be careful, conservative, you might want to start out with slightly healthier patients. I wouldn't do this for the first time in a very frail ASA4. Like so many of the things that we do, we start cautiously and we gain some confidence and experience and then expand from there. But hopefully I've been able to assuage for your viewers and listeners some of the more common concerns.
No, that's great, Prof. And the other questions for our critics who are probably potentially not convinced that, the benefits of methadone can overcome some potential setbacks for the use of it, especially in this day and age where we are quite concerned about, opioid crisis. What would you say? What would your reply be?
Well, I think that looking at the very big picture, I think that it's important to realize that the opioid crisis has nothing to do with the operating room. It has nothing to do with surgical anesthesia. It has very little to do with surgery. Now, having said that, we knew in the past that surgeons sometimes sent patients home with too many opioids, and that's changing. And if patients have less postoperative pain because you're giving methadone, maybe they need even fewer take-home opioid pills. And so the practitioners today, we can't escape hearing about the opioid crisis, whether it's in the lay press or it's in the medical press. And there's been a lot of reaction. Sometimes there's been a little bit of anti-opioid hysteria. But it's important to understand where those problems originated and what they are. And it's the opioid crisis was basically due to oral opioids given to pain patients by primary care practitioners. Those patients, it was not indicated, not appropriate, not effective, and they were misused. I don't think that we should deprive patients of adequate postoperative analgesia because primary care practitioners gave them too many oral opioids. We need to keep these two things separate in our minds. Anesthesiologists have a responsibility to deliver high-quality analgesia to patients, high-quality care and cautious care, and I think that we want to do it in the best way possible. And depriving them of adequate analgesia, and sometimes opioids are the best answer, depriving them isn't the way to go. Our goal is to figure out how to deliver high quality care and how to create anesthetic regimens that are best tailored to specific operations and specific patients. We talked a little bit earlier about the concept of protocols. Now, this brings up a little bit of a philosophical discussion about the concept of personalized medicine versus protocolized medicine. On the one hand, we talk about the fact that one size doesn't fit all, yet we're trying to come up with protocols for one that's going to fit everybody. I think our goal and our challenge, our opportunity, and our reward is to individualize and optimize anesthetic regimens for each patient.
Thank you all very much for staying this late. I might open the floor to questions, and I might also let our experts have their inputs into the session and any further insights that they might want to share. Please go ahead. Thank you.
Raphael Howe, orthopedic surgeon from Melbourne. Thanks for inviting me. I just want to make a comment about the sort of opiate problem. I think I feel that in a way we've gone the other, the sort of pendulum swung the other side, that post-operatively we're limited to so few number of narcotic analgesia that can be discharged with patient, especially with the knee replacement patients, that we only allow like 5 endone, which they will consume within 48 hours. And our residents are constantly fielding sort of patients' requests to have more, 1 or 2 days after discharge. So maybe with more common use of methadone, we can reduce that problem. Hopefully the pain post-op requirement or the post-op narcotic analgesia will become less, and ERAS in a way will also work better.
Thanks, Ref. Did any one of our other experts have anything to add and also about the sticker comment? David, please go ahead.
Look, thanks. And thanks again for a great session. I think the sticker comment feeds into one of the issues that was of concern from VPCC, which is avoiding this problem of the long tail being compounded by polypharmacy in the post-operative period. And I think that's the message of the sticker, is twofold. It's one, to highlight that you have got a long tail here. You've got a non-titratable background level of an opioid, and it's a potent mu receptor agonist, and it obviously works very well in the way it works, but its kinetics are very complex. So the concept of thinking about it a bit like intrathecal morphine is not a bad one. And to avoiding the other sedating analgesics excessively, not overdosing on methadone, I think is a good message here. I am concerned about titrating methadone in PACU. I think it's appropriate to, if you're going to use it, you've chosen your patient who you think it may be of benefit for a suitably long procedure with a suitable expectation of post-operative pain, that you do that. But it is a bit of an estimate, and you've got to adjust for age and comorbidity, and I would be starting with more healthier patients. Then you titrate, because anaesthetists titrate. That's what we do. We titrate our medications according to need. And although PCA has many failings and many weaknesses, it does enable post-operative titration to occur once you've got to that point. Whereas if you give boluses of methadone, you're sort of titrating to the acute pain response, but you don't know what that tail is going to be like. So the final comment then, because I know we're running late, is then this discussion we need to have about, well, what are the post-operative observation frequencies going to be? And look, patients having big spinal surgery, they're getting neuro-obs overnight anyway. They're going to be disturbed. There's nothing really adding an hourly sedation score is not going to add a lot to the misery of their first post-operative night. And it adds a layer of safety as well when you're providing with an analgesic technique, which may be variable. And we've talked about the variability of that long tail afterwards. So I'll just leave it at that. I think the sticker's a good idea, but it does highlight those two aspects, the monitoring side of it and not layering in too much uncontrolled extra sedative drugs.
Thank you very much, Prof. Noam, please go ahead.
Thank you. I 100% concur with pretty much everything that's been said. I think what you do see is that there's a strong selection of patients that will have significant sedation, and you'll see that in PACU, and they'll have an extended PACU stay. And I think that's probably the group of patients that is probably more at risk, and you'll see it earlier on. So what we often do with some of our methadone patients is we actually plan for them to have a prolonged PACU stay, so at least of about 2 hours, so that we'll see if there's anything happening. I think the other group is the OSA patient or the undiagnosed OSA patient, to keep an extra careful look at them and maybe keep them a bit longer in PACU and try to avoid, I guess, the other sedative agents. So I don't give ketamine with methadone, but I'm happy to give ketamine post once I've demonstrated a need for it afterwards. That would be my only other tips.
Thanks so much, Noam. James, Stephanie, or Tony, did you have anything else to add? Otherwise, we might hand over the time to Vida and we'll wrap up there.
I thank you guys so much for having us. I think you guys have done an amazing and very comprehensive job in combing through all the literature, even some that are more recent than what we had published. I will put in one more caveat that I think I echo Tony and James in saying this, that I also use Precedex and ketamine along with methadone intraoperatively, but under the monitoring of either like a Sedline or a BIS, just to make sure that I'm not overdosing and that by the end of the case, patients can wake up fairly quickly and don't have a prolonged PACU stay. So if that's available to you, definitely use it to your advantage. But if not, I think always being a little bit more conservative, trying to prioritize safety in patients is definitely a noble goal. And thank you so much again.
Thanks so much, Stephanie. Vida, I might let you close on the meeting.
Thank you, Sarah. And let me congratulate you and your team on screen and panelists and the participants who have been attending this event. It's been magnificent. I think it's a testament to its popularity as an event, that we would have had more than 1,000 registrants, but like Jennifer Aniston, when she broke the internet, we nearly broke Zoom. We will be editing this video and supplying it on the ASA website as well, so that those people who had to leave early will also have the benefit of your magnificent efforts tonight. Congratulations. You deserve all of the credit that you get, and thank you very much for bringing this debate so alive. Thank you.
Thank you so much, Vida. Thank you all very much.